well, there's kind of a subscript that you hear that you don't quite belong here. When you start to feel that, those exclusion processes kind of slope towards paranoia. And now that we know more about epigenetics and how stress can affect, we have more tools to understand how what happens in society can translate into disease.
Yeah.
What was helpful to those people, the most therapeutic aspect of the recovery was reconnecting, rebridging, reshaping the broken social ties, giving them another role within society or a way in which they can contribute and belong to society, maybe repairing the broken ties with their own family or with their cultural group. And this is what was felt as therapeutic to them.
Yeah. Ladies and gentlemen, welcome to the newest episode of the Bridging Podcast, a podcast where you can learn, practice, and transform in any area of your life if you do the work, as always I say. Today, I'm so excited to introduce you to Dr. François Bourque, a social and transcultural psychiatrist who focuses on mental health of immigrants and young people with conditions like psychosis, dealing with issues like social exclusion and stigma. And interestingly enough, he's also professionally trained as a pianist. After completing his residency and fellowship at McGill University, Dr. Bourque got his PhD in Epidemiology and Social Psychiatry from King's College in London. And he has worked for over a decade with the Cree Inuit communities in northern Quebec, Canada. His research looks at how social factors affect mental health and explores the connection between society, ethnicity, and psychosis. And Dr. Bourque aims to understand how our social world influences mental illness to improve overall community health. Dr. Bourque, François, welcome. It's great to have you here.
Thank you so much. Thank you for the warm introduction, Ursula. Very nice to meet you again.
Yeah, it's great to have you here. So, François and I, we were in San Diego last March 2024 on a meditation retreat, and we were sitting next to each other. We didn't really talk. We didn't talk before the meditation. Then once we started meditating, I lost my balance in the meditation and I just fell off my chair. And because I lost my balance and I fell off my chair, my head was almost hitting the chair behind me. And Francois, luckily, I heard this at the end. He just pushed the chair away, and then I actually fell on the floor instead of hitting my head to the chair. So thank you for saving me, Francois. And after that, we started chatting and talking, and I found out he's a psychiatrist. So before we start diving into psychiatry, can you please tell us about your journey on how you got in psychiatry? You studied medicine and then you decided to go into psychiatry.
It's a whole process. I would say, I was studying music and medicine at the same time. And it was very, I don't know, I could not choose between one or the other. I guess in those days I felt like, oh, am I this? Am I that? I didn't know. But I remember I had an inspiration. His name was Albert Schweitzer, and he was a great musician, and he was also a physician who ended up, doing, how can I say, medicine in Africa, built a hospital there while still having a career in music. So it was like, this is something that is possible. So I kind of did both for as long as I could, and then I had to make a difficult choice. So I chose medicine, kind of having the thought that I could still go back to music as a physician, but probably it'd be harder as a musician to still be a physician. So that drove me towards medicine. And then in medicine, I just remember I was fascinated by every topic. At first, I was into anatomy, surgery, then internal medicine. And eventually, I got much more interested in fields like palliative care, remember oncology, and psychiatry. It's just that psychiatry was a bit unfamiliar. I'm not going to say taboo, but I didn't quite know what to expect about it. But I did a few rotations. I remember rotation in psycho-oncology, for instance, and that's where I realized, okay, you're really all about the human experience of going through the illness. So I was more about the human going through a cancer than by the type of cancer cells, for instance. So
Mm.
that's kind of what oriented me towards psychiatry. Plus, when I went into psychiatry, there was that notion that there was still the arts, the artist in myself. And I remember that, going to psychiatry, it still felt like uncharted territory. Yes, we know many things, but there's so much we don't know about the brain, the human psyche, human behavior, and everything. And it just felt like, you know what? I could still go to see a piece of music, a piece of art, read a novel, piece of cinema, and maybe learn something about the human condition, which will have an impact or give me some insight in my role as a psychiatrist. So that was part of the
Yeah.
process towards psychiatry. And then I chose to go to McGill University specifically because it was well known for, how can I say, it was well established, a world center in the field of transcultural psychiatry in working with immigrant populations and Aboriginal populations. So that's really what was kind of driving me to go to pursue psychiatry at McGill University.
Yeah. And then interestingly, you went to King's College in London and you did your research on transcultural psychiatry and you started interviewing immigrants also in the Netherlands while you were studying or doing
Mm-hmm.
your research in London. And interestingly, now in front of you, there's someone sitting that is third generation immigrant in the Netherlands. Isn't that funny?
Very interesting.
which is which you saved the head in during a meditation. So so Francois, we had many chats in San Diego later on, online, and you told me about your work in psychiatry. um, there was like this transformation in your work for you because you went yourself through something. You started working as a psychiatrist, and then you started seeing patients, and then all of a sudden, or I don't know if it's all of a sudden, I'm not a psychiatrist, you are it. Then you got yourself, you were facing some health issues, and then you had to pause with working. You pause working, and you had to work on you, and then just got back into psychiatry as actually maybe a totally different person, if I may say. So can you talk us through that process? How were you working as a psychiatrist? What happened? How did you deal with that, and how did you get back?
You know, I talk about it as a continuum. Even before I had to face my own issues, it was an ever evolving process and journey. Just training to psychiatry, and training to psychiatry. At some point, I was dealing a lot. I was very interested in people with first episode of psychosis, early psychosis, and somehow I noticed like there seems to be lots of migrants among them, and that puzzled me. So that kind of brought me already to, is there something going on in relationship with migration and psychosis? So that was one of the topic of my Masters of Science at McGill and of my fellowship as well. So already I was looking into, is there some sort of interface between the migration process or the ethnic minority status, the society, and what happens as psychosis? So already I was unlearning some of what I had learned, because one of the things I had learned is that schizophrenia was universal. It was 1% across the world populations. But I was confronted by what I was seeing, and that brought me to do research into that.
What were you seeing?
What I
You
was
said I
seeing,
was.
I was seeing that there was more. I was observing in my practice that there seemed to be that migrant populations seem to be overrepresented in the clinical population that presented with psychosis. So, and looking at the literature, there was already some epidemiological literature suggesting that this was the case. So, but there was no explanation quite. It was just kind of going outside the box because the main model was schizophrenia is universal, 1% across the world population. So that's kind of what intrigued the researcher in me, who was also observing things on site, working in practice in Montreal. But that went further as I started to work with the Inuit population and eventually with the Cree populations as well. So I started working up north, I think around between 2008, 2010. And then I had to practice then since 2010. And whenever I was practicing psychiatry up north, I mean, I'm working in the Great North, I'm working in the Arctic region, I'm working with some patients who were born in igloos, actually, who've gone through major transformations over the last few decades. And I could feel that the psychiatry that I had learned in my books was not quite applicable to them, or I had to revisit things and to change from my posture of being an expert to realize that, well, I may be an expert in many things about psychiatry and pharmacology and everything, but I'm certainly not an expert about being an Inuit and living in the Great North. So I had to reconstruct things. And the more I was working with either Inuit or with migrant populations, the more it was obvious to me that whatever I was experiencing was not just about them being a patient and somehow being predisposed to an illness and or any fault of them, or it was to do often with the social context in which they were. So when I saw an Inuit, they often came from a family from generations who experienced different form of trauma, such as generational
Francois,
pull. Yeah.
I'm going to pause you for a
Yeah.
moment for those that are listening or watching this right now, for those that don't know what an Inuit is. Can you just briefly, shortly explain that to us? What is
Okay.
an Inuit?
So that's interesting in itself. I mean, so we're talking about the Aboriginal populations in general. So within Canada, we have the First Nations and Inuit. What is sort of the big distinction between them is that most of the First Nations are people that live what under what we call the tree line. So there's kind of a geographical line beyond which trees cannot grow. So below that line, you'll find most of the First Nations were actually people of the forest. But beyond that line, you're actually in the Arctic, in a land of tundra. You're essentially people of the ice, you could say. So all the people in the circumpolar north could be described as the Inuit populations. Now there will be
Mm,
difference on how they call themselves. Those in Alaska might call themselves Eskimos, for instance. Some other groups will call themselves Inuit. There are other people in Greenland, for instance. But
yeah.
essentially, that's what I'm referring to. And those that I worked with were mainly the Inuits living in the Arctic part of Quebec
Yeah.
in Canada.
I think, for European people, especially Eskimo, would make sense to understand the concept of what you're talking about.
Right,
That's why I was asking.
but Eskimo is it's not a term that is approved or accepted by most of the Inuit communities, only by some, but for historical reasons. So it's just something to be aware of. So if you encounter people who come from the circumpolar north, it's probably better to verify with them. How do you like to be called, or what do
Yeah.
you identify as a group? Yeah,
Yes. I can feel the scientist in you. So
scientist and
keep going.
culturally
Yeah.
appropriate.
So
Yes,
you started working with the Inuit people, and before you actually started facing your own health
yes,
issues.
yes.
Just carry on, please, from there.
Sure. So working with Inuit people, I mean, already there were little things. It was so interesting. Sometimes I would ask them, the basic questions that I would ask any of my patients in the South, like, how many children do you have, you know? And in the South, when I say the South, I mean like in Montreal, people would just say, you know, oh, I've got, you know, two children, or I've got one or three, whatever. Like there was kind of a very easy, clear question. Sometimes when I would ask that same question up north, they looked at me like, I don't know, or they might say something like, well, I have Lucasi, and then I have Sammy, but I adopted my granddaughter, but I used to have and then somehow they would count like, which one do you mean? You know, the biological, the one that lives with me or that I take care of, and the answer would be kind of fluid. And it was very interesting. It was not a notion of like, these are my children, they belong to me. It was a very different notion of the family, of the community, of how they view themselves. So just that was like, okay, there's a fundamental difference on how they view themselves. And we're talking 10, 15 years ago, at someone, they were talking about the impacts of climate change already. Here it was something more like theoretical, you know, oh, we need to be aware of the climate change, it's going to come and everything. And some people are, well, it's not really true, or is it? And but over there, they're like, well, we're seeing it, you know, the animals are not the same, our climate is not the same, we cannot trust the ice as before. So they were already experiencing some effects of the climate change. So it was very obvious to me that part of the mental health could not be, you could not think of it without thinking of both the social environment and the ecological environment and the social
Yeah.
historical context of colonization
Yes.
and everything that went with it, a series of traumas. So already there was a sort of a unlearning process as I tried to be there and provide the most culturally appropriate and culturally safe care. So that was part of my journey. And as I did that, I went to London, UK, studied over there for 5 years to go further into understanding what's that relationship between migration, ethnicity, social context, and psychosis. That brought me in London, where I looked at migrant groups. I was looking at
Not only in London, but around Europe and UK, right? You looked at
Actually,
mig.
yes, I was looking at the overall epidemiology, which was mainly driven from Europe. But in practice, I did some field work in London, UK, in Paris, in France, as well as in Amsterdam, in the Netherlands. And I looked at epidemiology, which was telling me, okay, these groups have higher risk or lesser risk. So, for instance, in Amsterdam, I could see that population of Moroccan origins or of Suriname origin seem to have higher risk of psychosis than the native-born Dutch population.
This was depending. This was in your research. You found out this.
Yes, I mean, there was already some data about that. So, but I
Hmm.
explored that from, I guess, from the epidemiological lens, looking at the landscape of the epidemiology, the incidence of psychosis among those groups. Um, but it did feel that if we want to understand something that is really complex, something that seems to be different across times, across space, across ethnic groups, and something that is not just related to the first generation migrants, but also applies to the second generation who were born in the host country. So that brought me that if we want to understand something that is such a phenomenon embedded in society, we need to use tools or another way of thinking. Like epidemiology and numbers are not enough. So that's why I use mixed methods research, which allow me to combine epidemiology, but to draw illness narratives of migrants who developed psychosis. So I looked in depth at that in different groups. And that was fascinating because it was very clear in what they described to me, the way that they saw their illness, the trajectory of their illness. Essentially, if I had to summarize that, it was a succession of stressors, but in their social world. It was sort of an
Hmm.
accumulation of social injuries, if I may say, like the experience of discrimination, the experience of adverse interactions with the authorities or the police, the experience of having poor access to housing or even homelessness. And that was very interesting. So homelessness seemed to be something that preceded the experience of psychosis, that led people to be in such a vulnerable state and exposed to major stressors that this would lead to psychosis, as opposed to someone who has psychosis that leads them to be homeless, which was the
Mm-hmm.
notion that we commonly had. Also, the experience of discrimination. And among the second generation migrants, sometimes they had everything they needed. They had a great family setting, they were already settled in the host country. Yet they had to deal with sometimes the very high expectations of their parents or their culture of origins. They had to deal with, which is my culture? Is this my host culture where I'm living, or is this the cultural background of my parents and their values? And sometimes there was a shift or clash between that. And sometimes there was also a notion, and that was very traumatic for some of the second generation migrants. It's when, for instance, they grow up feeling that, I am British, I belong here, this is home. And then somehow when you start to try to get access to education, home, property, or other things, or you encounter an adverse interaction with, authorities, and you realize that, wait a minute, it's like they don't look at me as if I'm British. They just see me for
Mm-hmm.
my skin color or as someone who comes from elsewhere. So you
Mm-hmm.
can see this is the kind of social
Yeah,
injuries
yeah.
that was part of the trajectory towards
Yeah.
psychosis.
Like like we all face them, or we all actually also maybe unconsciously we are actually
Mm,
also doing it to others. Like you, I would love to
yeah.
give an example of that because I am second, third generation. My granddad came and then my dad was 14 when he came and I was born here. And I remember I was flying to the States a few months ago. Maybe it was a San Diego flight. I have no idea. And then I met this Dutch couple. We were just chatting, and then all of a sudden, the lady said to me, "Your Dutch is really good," and I was like, "Your Dutch is also good," and we had to laugh. I was like, "What?" Yeah, I was born and raised here. That was, for example, one thing. But
Yeah,
I
yeah.
also saw in social media there was this Moroccan Dutch journalist woman, and she went to an event, and then one person asked her like, where do you come from? And in Dutch, when you say where do you come from, it can also mean like, and she said like, but again this question, is it so important? But actually the guy was only asking from which company do you come for to this event, you know. And she already felt like this is like, I loved it that she was so honest about it,
Mhm,
because she thought the guy is judging her about which country she's from. It was only a question, from which company did you come to this
mhm.
event? He was just showing interest, right?
Yes.
So we all do that, but it's, yes, it injures us. It's this is my, I don't know if this is the concept, with my own feeling, it will be also it could feel as a bullying, that you are like kind of
Yeah.
bullied deliberately or unconsciously. The woman in the plane was not bullying me, like I'm gonna say her Dutch is good. She was kind of giving me a compliment, but at the same time assuming I would not speak that well Dutch,
Hmm,
my
hmm.
native language.
Yeah.
Interesting.
This is the kind of, all those things, they may not be, they might not be blatant or obvious, they might be subtle, but even subtle, these are what some people would refer to as the microaggressions. If you just encounter once or twice or very random in space, well, it may not have, much impact and everything, but if there's some that are more dramatic, or if it's something that gets repeated over time, well, there's kind of a subscript that you hear that you don't
Mhm.
quite belong here, or you can start to feel that. And when you start to feel that, those exclusion processes start to, you know, kind of a slope towards paranoia. Am
Yeah.
I home here? Am I accepted here? That can start to make you hypervigilant. if you already have experiences.
Yeah.
And now that we know more about epigenetics and how stress can impact disease, I think we have more tools to understand how what happens in society can translate into disease.
Yeah.
But what is this? What was so interesting about that? I mean, there were variations also in London versus in Paris. You don't talk about ethnicity in Paris. It's kind of it's a taboo subject. You don't talk about it the same way at all as you would in the Netherlands, where it's okay to describe, the ethnic belonging of groups. So already we have to contextualize those phenomena. They're not the same where you talk about things. And what was so interesting is what was helpful to those people. It was not about going to the hospital. It was not about the medications that they took. Yes, they needed them. Yes, sometimes it was perceived as helpful, but all what they told me almost universally was the most therapeutic aspect of their recovery was reconnecting, rebridging,
Mm-hmm.
reshaping the broken social ties, giving them another role within society, maybe work or a way in which they can contribute and belong to society, maybe repairing the broken ties with their own family or with their cultural group, giving them a home where they feel safe,
Yeah.
making them feel dignified as a human being in spite of whatever happened, as opposed to just the illness. Some people have been excluded also as soon as they manifested symptoms, excluded by their own group, that kind of things. And this is what was felt as therapeutic to them.
Yeah. So to just summarize it for a little bit, what you're saying, what you found in the study when you were doing the research in King's College London, where you were just getting data from Paris, Amsterdam, and London from immigrants, especially second generation immigrants, and then what you found is they have a higher risk of social injuries, like what we just talked about, and based on the social injuries they also have a higher risk on psychosis. So, what happens exactly when someone is going through psychosis? Do I say it right? Are you
Yeah, yeah,
going through
yeah.
psychosis? Are you having a psychosis? What's happening? Would you help us to define it a little bit?
Now, there's a whole spectrum of psychotic disorders. If we can say, I guess one of the well-known would be schizophrenia, but we also know about bipolar disorder, which can manifest as well with psychosis. There are a few disorders. There are debates about the meaning of those constructs right now. They're not necessarily fully universally agreed. Um, but I guess the focus or there was a change within the last 2 decades, a movement that looked at early psychosis or early intervention for psychosis, no matter what's the underlying cause or diagnosis. And for that, we just look at the experience of psychosis itself, which
What is the experience of psychosis?
it can manifest in various ways, but usually when we refer to psychosis, there's some element or some symptoms which imply a form of the connection from the reality, whether it is through perceptions. So perceptions that would be erroneous. So what we would call hallucinations, for instance, having
Hmm.
visual, auditory, or other kind of hallucinations, or it might be erroneous beliefs, like a tightly held belief that is contrary to what most of the culture would believe, and whoops, and that is held tightly by a person that would qualify as a delusion. So that could be the conviction that the television is actually speaking to you, which might be an idea as of reference, or the conviction that when you walk through space, that there are lots of messages within a city that are actually targeting you or trying to tell you things. It could be about being convinced that there's some sort of conflict, or there are people who are out against and their cameras put specifically for you. There are lots of examples of how it can
So
manifest.
Do
It
I understand it right? It's not a moment thing, but it can, happen uh,
it
as an experience during the day, and all the time. Like, for
yeah.
example, someone thinking like, everyone is against me again when I going out, like, they're gonna follow me, or things like
Yeah.
that, or
Yeah, things like that. So you can have, I mean, there's a spectrum actually. We can all have ideas. We can all be at some point, concerned. Well, could this person be following me, perhaps? Or I think I'm being followed. I mean, we could have that. That can be part of human. We can have a tendency to believe that a lot. Now, when you become convinced of that, in spite of evidence to the contrary, or in spite of the contrary accepted belief within your society, which can be a vague definition. This is where
yes,
we're going to go into the territory of delusion as opposed to ideation or feeling. So same with perceptions. You can have heightened sense of seeing things or perceiving things with your hands, with your senses, everything. But when you truly perceive something which is beyond your senses and that nobody else would perceive, that would possibly be deemed as hallucinations.
yeah,
I want to be very cautious in that because especially being trained in transcultural psychiatry, I do know that there's some experiences that can be tainted or that can be explained within one's cultural framework. So we need to be aware of that. Just as within griefs, within an acute grief, someone might hear, the lost one, and this might not be deemed to be an hallucination, such as what we would find in a psychotic disorder. Now, so there's a notion of whether there are those symptoms. Typically, we would qualify them as psychosis if they persist for more than a day. But now the variations, it could be very temporary as a result of drug exposure, but it could be longer term. It could be on top of post-traumatic stress syndromes. It could be part of depression, for instance, where you feel so guilty. You're sure that, I don't know, I'm going to say an example, that you're responsible for the COVID pandemic. Somehow it's your fault and you should be punished for the COVID pandemic. That's an example of what
mm-hmm,
would be
mm-hmm.
a delusion that we might find
Yeah.
in depression.
Yeah, like, but for example, with the immigrant part, look, if we go back a little bit like that, so my both of my parents were born in Turkey, and then when we were growing up, my brother and I, we are almost the same age. We go to university and we just learn a lot of other things than the culture that we grew up with in the house, literally in the house and in the neighborhood, because we were living with a lot of Turkish and Moroccan people, my friends. So, and then we get exposed to all new things and all, and then we also are becoming more and more Dutch, right? And then also feeling a little bit guilty towards, like, did we go maybe a little bit too far? Are we not Turkish anymore back home? Like,
Hmm.
when my mom said, hey, but
Yeah.
this is what we learned, why do you do this? And I'm like, yeah, but everyone does it. Like, feeling that guilt of maybe I am just saying bye, or maybe I'm being separated from that culture.
Hmm.
I'm not saying with this that that was a psychosis. Maybe
Hmm.
I'm not sure. I'm not a psychiatrist here,
Hmm.
but really feeling that guilt. And I know from my friends, and I haven't done research, but I have
Hmm.
lived the experience. I
Hmm.
was with a lot of Moroccan, Turkish
Hmm.
friends, not that much Suriname though. So, and I know many people had that in a very different way, feeling the guilt, feeling the shame.
Hmm.
Um, these were all part and of these bicultural identity.
Yes.
One of the reasons I started doing self-development work in 2014 was because I was
Yes.
stuck in the two cultures, in the religion. I grew up as a
Hmm.
Muslim, and you just grew up in a atheist community, atheist, or maybe some Christian, Catholic. I mean, you are just really stuck in between. And
Yes.
until I started embracing, I am and not a half
Right.
half, but I'm Dutch and I'm Turkish
Yes.
and I'm also a global citizen, by the
Yes.
way.
Yes.
You know, I'm a
Hmm.
human. By the way, I'm
Yes.
also a human,
Yes.
human being. I'm
Yes.
also energy.
It is so interesting what you say because what you're describing relates to what was said in the illness narratives that I've collected. I used a wonderful tool which is called the McGill Illness Narrative Interview. It's a tool that was developed to try to elicit the illness experience, but across cultural groups. So independently of where you come from, you can have a model to explain what led. You might have causes like in a rational way. You might have analogous experience like, oh, I'm experiencing this, which is similar to what went through so and so or my aunt. Or you have like what we call chain complexes. Well, this happened and then this happened. So therefore this must be connected. But in those stories, that's where I saw there was a big distinction between the first generation migrants and the second generation. And among the second generation, what you just described, it was really commonly described as part of the how can I say the forces or the stresses they had to deal with, and some of them were describing it's like I don't belong, like I don't feel that I belong to the Dutch society and or to my Moroccan culture either. So there was that sense of disconnect or who am I?
Disconnect.
What am I? And that sense of disconnection is one of the things that really seems to be when you feel disconnected from society, that seems to predispose you on the trajectory for psychosis. And there's another beautiful piece of evidence, actually, which is driven from research conducted in Amsterdam, I believe, or actually in the Netherlands, and they look at the ethnic density hypothesis. That's very interesting as well. What they notice is that the migrant groups that lived in neighborhoods where they were more densely populated, where there was a higher representation of that migrant group, they were much less likely to develop psychosis than the same migrant groups who were much more isolated or living in a neighborhood where they were much less represented, which we call the ethnic density hypothesis. So my colleague, Professor Veiling, that did some of those research, which I also think are fascinating, but also point to social phenomenon at root of what we're discussing.
But this is so interesting, Francois, because I grew up in the neighborhood with a lot of Turkish and Moroccan people, and then I remember I went to what is it, high school with almost, if I can say, white people. I did not feel at home, not at all. And now I live in Amsterdam, and looking for another house to live in, and I was thinking, oh, this place is a really nice place. Another place in Amsterdam, but I said to my friend, but I don't think I can live there. I don't want to live there because they're only native Dutch people. I mean, and I love them. And I mean, I'm also Dutch, but it does not feel right for me. I really want to have all different culture in the same uh, area so I also can bond with them. So it's not really weird or interesting that I have a cultural background or that I'm just a human, right? And it feels there more. I'm a human and I'm not labeled as whatever I'm
Yeah,
labeled for. Or the same what
right.
I'm doing most probably towards other people, by the way.
Right. And you found
So,
your anchor. I mean, it's great because you're somehow naming some of the resilient strategies, I would say, and you describe some ways, some process by which you found your ties, the connection, the support that you needed, and you found a way to feel whole, if I could say,
hmm
as opposed to
hmm
fragmented. So
hmm
you can see,
yeah,
the wholeness, but within mental health as opposed to feeling fragmented.
yeah.
Psychosis has a lot to do when you feel fragmented as a person in some ways or within a
Mm,
society. So I think that's one of the way we can talk about that. And your experience is very, I mean, it's
yeah.
great. You didn't have to go through psychosis, but you've definitely experienced some of the phenomenon that were described by those who eventually experienced psychosis.
And I don't know, maybe I did it. I not that I know in my 20s or 30s. I'm now in my 30s, but it's now it's easy to talk. But back then I had so many things going on in
Hmm.
high school, like really not, I want to be alone all the time. I didn't want to play with anyone. I didn't want to do homework with someone. I wanted to do everything alone, 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 alone. And eh, we don't need to go there anyhow. But what I'm understanding is community is extremely important, and not a community, but a community where you can feel I can anchor
Hmm.
in this. This gives
Yes.
me a safe place.
Yes.
I can be who I want to be, or who I am,
Yes.
maybe.
Yes. I mean, if ever we go towards, I mean, I strongly believe that we need to think of mental health from a social perspective, especially with the epidemiology, the epidemics of mental health issues we have. And I think we need to move towards a resiliency framework as well. But one of the keys of resilience, I mean, we can talk about them at a later point or a later interview, depending. One of them is C for connection, community.
Mhm.
And that's definitely one of the things that emerged in my illness narratives, or I would say as part of the healing narrative. That that need for belonging, that's part of us
Mhm.
as human, and to belong to a safe space where you can be yourself. It could be part of your own community, but it does not need. Many people told me it would have been helpful to have a role model who came from my own background, but who was feeling, well and integrated within their society. Some other people told me that they felt that by their role as a youth worker, for instance. Others said that they felt that through their sports activities or something. So there are different ways that you can go and build that key, that resiliency
Mhm.
piece, but it's a fundamental one. And we need even more so, I think, at our stage right now and in urban environments. I mean, the epidemic, as you know, has been very challenging for the sense of communities at many levels. So, is that related to the rising rates that we're seeing for many mental health issues? Well, I'm not sure we have proof or conclusive data about that, but there's certainly a sense that many people have felt more disconnected
Mhm.
in the last few years in the post-pandemic world, and many have suffered more
Yeah.
distress and potentially mental health issues as well.
Yeah.